Dr. Paul Connelly, who's again one of the Centre of Excellence Clinical Research Fellows, and he's going to present a talk entitled Cardiovascular Health in Transgender People. So thank you, Paul.
Hello, thank you very much for the opportunity to speak today. So my PhD is looking at the relationship between sex and gender and cardiovascular disease, with a particular focus on the cardiovascular health of people who are transgender. So just to go over a little bit of transgender terminology, as Professor Pilot has already gone through, we've got to think about sex and gender as being related but different components. So sex is biological. We're assigned sex at birth related to our essentially external genitalia at the time. And most individuals, their gender or their gender identity, which is a component of gender, this will align and you will have gender congruence. And the vast majority of individuals will therefore be cisgender. But in some individuals, there is a kind of mismatch between gender identity and sex, which results in gender incongruence and may result in gender dysphoria, which can be quite a profound sense of anxiety or depression related to that kind of sex and gender mismatch. And these individuals are transgender. So somebody who is assigned a male sex at birth, who identifies as a woman, is a transgender woman, and somebody who is assigned a female sex at birth but identifies as a man is a transgender man. This is quite a simplistic kind of model for this. There are people who are gender non-binary, people who are gender fluid, but for the purposes of the talk today, I'll focus broadly on transgender women and transgender men. The people who are transgender don't always receive treatment, but when they do, they can receive feminizing treatment in terms of high-dose estrogen therapy, which can be given at sometimes 4 to 8 times the dose of HRT that we provide for postmenopausal women, and in addition to anti-androgen therapy, so GnRH analogues or cypretone acetate. Masculinizing treatment, which is utilized by transgender men, typically consists of injectable testosterone or testosterone transdermal gels, although these individuals can also use GnRH analogues for the suppression of their menses, typically within the first 6 months of treatment, as this can be a source of gender dysphoria as well. So in terms of the size of the transgender population, what do we know? Well, there's a lot of uncertainty here. Not all seek out hormonal therapy. Some hormonal therapy can be obtained from non-medical sources, and there is a significant stigma in certain societies and cultures with regards to healthcare access for these individuals and seeking out medical therapy. Some of the best data that we have is from the Behavioural Risk Factor Surveillance Survey conducted in the US that suggests about 0.5% of the population are transgender, and there's certainly data from Central Europe, particularly Denmark, that shows it's around 0.7%, potentially as high as 1% in Central Europe. What is certain is that if we look at the data from prevalence studies over time, the rates of people identifying as transgender is increasing substantially, and this might have a quite significant impact in the future with regards to healthcare resource and equity. So why are we interested in the transgender population with regards to cardiovascular health? Well, if we think about people who are cisgender for a moment, it should be fairly apparent that if you look at the presentation, the pathophysiology, or even health outcomes in males and females, that there are quite significant differences between the two. And this sexual dimorphism might be related to the sex hormones that we essentially secrete. I think one of the best exemplars for this is the relationship between sex hormones and blood pressure. If we look at children, they typically have equitable blood pressure between boys and girls. However, following puberty, boys tend to have higher blood pressure at this time. And overall, if you look at age and hypertension prevalence, which you can see on this graph from the left, that hypertension prevalence does appear to be higher in males up until the point of around about the 6th decade, where thereafter women surpass men with regards to the prevalence of this condition. And that coincides with quite a significant drop in estradiol levels that they experience with the menopause. So it's likely that sex hormones are playing a role here At the kind of molecular and cellular level, it's evident that estradiol and androgen receptors are expressed throughout the vasculature, in particular within endothelial and vascular smooth muscle cells. Estradiol itself is believed to have broadly cardioprotective effects. It promotes vasodilatation, reduces oxidative stress, whereas testosterone has a bit more of a complicated picture. It can promote vasodilatation, but also vasoconstriction in certain settings, and can increase oxidative stress and inflammation. However, in certain models of, for instance, of ischemia, can be cardioprotective, so a little bit more complicated. In addition to the kind of the biological, what the kind of research in this area also provides us with is the opportunity to look at sex and gender from a different aspect. So in cisgender populations, we'll be looking at the kind of intersection and interaction between sex and gender, whereas within transgender population, it allows us the opportunity to essentially review a cross reaction between these two concepts. So what evidence is there? Well, we published some data in hypertension a couple of years ago, and are kind of walking into the project, there was an assumption that transgender men may have a higher risk of cardiovascular disease, given that cardiovascular disease is more abundant in men, and they would be essentially moving from a kind of a lower risk to a higher risk phenotype. However, there doesn't appear to be much signal whatsoever for a higher risk of cardiovascular disease within the transgender male population. Conversely, there does appear to be an increased signal for ischemic heart disease in transgender women, and in particular quite a strong signal for ischemic stroke within that population. This plot on the right shows some data from Kaiser conducted in the US in a population of about 800 trans women, and you can see here that there's a twofold increase in the risk of ischemic stroke in transgender women compared to cisgender men, and that's threefold compared to cisgender women. So essentially we're in a situation where there's a kind of paradoxical relationship between how we think these hormones work within the vasculature and the kind of evidence that we have with regards to cardiovascular disease. But that comes with some caveats. There's significant limitations with regards to the data we have, absence of large cohort studies, lack of appropriate control populations, and there's often an adequate linkage with gender identity services to follow these participants up for a period of time for observation. So we decided we'd look a bit about blood pressure, and obviously blood pressure, hypertension is such an important modifiable risk factor of cardiovascular disease, and published a systematic review in the Journal of Hypertension last year. We identified 14 studies comprising of 1,300 trans individuals, and studies dated between 1989 and 2019. These individuals had mean ages of about 23 to 37. The median age for transition in Scotland, for instance, is 27, so fairly representative. However, there's quite heterogeneous hormonal therapies used, subcutaneous, sublingual, intramuscular. They were very heterogeneous. Essentially, what we found was that most studies did not show a change in blood pressure in trans men, and again, there did appear to be a signal for increased blood pressure in trans women following the commencement of hormonal therapy. However, again, there's significant issues with this data. All of these studies were quasi-experimental in that they had blood pressure recorded before and then after the commencement of gender-affirming hormonal therapy, didn't have multiple measurements, which prevented an interrupted time series analysis, for instance, and none of these studies had a control population. So even taking into account this kind of quasi-experimental status, the studies included were of fair to poor quality at best. So we published some research recommendations with regards to the conduction of prospective longitudinal observational cohort studies, looking at, in particular, blood pressure, but obviously a host of other cardiovascular endpoints, which is important within this population. So just to summarise and conclude, I think it's really important that we establish whether or not cardiovascular risk is increased within this transgender population, in particular trans women using estrogen therapy. This has to be achieved through both clinical and mechanistic studies, and good quality evidence is really key to this. We need to perform good quality studies. And what our hope is that if we can understand the mechanisms responsible for potentially increased risk within this population, it will help us understand kind of sex and gender differences within cisgender populations, but also provide an evidence base for risk management in the future of these people who are transgender. So thank you very much. I just wanted to thank the BHF for funding my research and the Centre of Research Excellence for providing research support and mentorship. Thank you.